Naomi, thank you. I think it's been a wonderful symposium. And I think it's timely symposium that we do highlight cardiovascular disease in women. Really is timely. Well, my task is discussing ischemic heart disease in women. And why is it important to learn about ischemic heart disease in women? And I think Naomi touched upon this in a very initial slides, is that coronary artery disease is in fact the leading cause of death in women throughout the world, at least in the developed world. And if you look in the United States, the annual deaths from cardiovascular disease or coronary heart disease is greater in women than in men. And this analysis was done in 1999, where you can see the number of deaths in women being much greater than that in men. Now, another fact that kind of got a little bit lost in Naomi's presentation, but which I actually want to highlight here even more, is that more women die from heart disease than cancer, chronic obstructive airways disease, Alzheimer's disease, and accidents combined. Yet our focus is more on cancer in this country. We should have more red days than pink days. I mean, if you just look at the audience, 1 in 3 of you will die from a cardiovascular event rather than cancer. So it's sobering that ischemic heart disease is a real major problem. Of interest is that sudden death has been slowly declining in men over years, and yet the prevalence of sudden death in women has stayed very high and is not declining. And in fact, the greater proportion die from sudden death presenting with an acute coronary event in women than as men, almost 10% difference. And women who present with cardiovascular, at least coronary artery disease, have more persistent symptoms, requiring more hospitalization and more care, and in fact use more healthcare costs. And when they do have coronary artery disease, they have lower ratings of generalized well-being. And I'll go into a little bit more detail into that. The paradox about the data I've just shown you is that women have less obstructive coronary artery disease and in fact relatively better preserved left ventricular function. And despite this, they have greater rates of myocardial ischemia and higher risk of dying. Now, why is that? Well, a couple of things. Not so sure we fully understand that. Firstly, if we look at risk factors, women have greater cholesterol levels than men after the fifth decade. And has been highlighted by a number of speakers here, obesity is prevalent in many women. We just completed a survey of young kids in Alex, of 1,000 kids, and at least a third of these teenagers had a high BMI. This is teenagers. Diabetic women have greater ischemic heart disease related mortality than diabetic men. And ischemic heart disease mortality risk increases with number of traditional risk factors as in men. And it appears that there's a clustering of risk factors specifically after menopause. So that's when the risk really goes high. Now, Naomi has also touched on this, is that traditional risk factors really underestimate ischemic heart disease risk, ischemic heart disease in women. And so investigators have looked at other novel risk factors which can improve detection of ischemic heart disease. One of these is C-reactive protein. And women on average have greater CRP levels than men. And in fact, it's interesting that this CRP difference arises quite early at the time of about puberty. And some commentators comment that this change in CRP levels may be consistent with the 2 to 50-fold increase, depending on which manuscript you read, in inflammatory mediated autoimmune disease. As in men, the risk of future ischemic heart disease events increases proportionately to increasing levels of high sensitivity CRP. Now, many of you know that we can measure CRP at a different level, a high sensitivity CRP, and epidemiological studies have shown that this to be more sensitive than the ordinary CRP levels. And these high CRP levels act synergistically with the other traditional risk factors we know, and that accelerates ischemic heart disease in women. The other novel risk factors that have come to the fore are disruption of the ovulating cycle, resulting in estrogen deficiency and hypothalamic dysfunction. And some women, premenopausal women with irregular menstrual cycles, have been reported to have a higher prevalence of ischemic heart disease as well. We do know that polycystic ovarian syndrome occurs in about 5 to 10% of women, but there's a clustering of other risk factors such as diabetes and metabolic syndrome, and this adds to the risk of ischemic heart disease. Now, Naomi has very elegantly shown the problem with the traditional Framingham risk score and the more modern, as the 2011 update guideline has shown, tends to estimate the risk much better for women. But the old traditional Framingham risk score is very poor in estimating risk in women. So we should really not use it. Others have, such as Paul Ritke, has developed the Reynolds risk score, which in fact incorporates the high sensitivity CRP into it, and in fact gives different weighting to the traditional risk factors to give you a much better estimate of risk in women. What about symptoms and prevalence of ischemia in women? It's quite interesting to know that angina occurs in women almost 25% more in women than in men. So they present more often with angina. And this is the other interesting fact. Those women who undergo coronary angiography, as many as 50%, in fact, do not have any major obstructive coronary artery disease. And this may be part of the problem. Even if you look at ST elevation myocardial infarction in women, those that in fact undergo urgent PCI, 10 to 25% of patients have no obstructive or significant obstructive coronary artery disease, as compared to only 5 to 10% in men. What about evaluation? What about the exercise ECG in men? We know traditionally this is a relatively poor test when you're testing for ischemic heart disease in women. It has a very low sensitivity and specificity, and some studies show as low as almost 30%. Now, if you combine exercise duration to the stress test, as well as ST segment changes to the Duke treadmill score, you tend to get a better prediction of ischemic heart disease mortality, but it's never as good as that in men. So as a result of that, there's been a whole host of new ways of imaging that have developed to try and non-invasively assess women with symptoms. Stress echocardiography, SPECT nuclear imaging, PET scanning, and MRI, all very useful. Unfortunately, they're expensive technologies, but they yield much better results. The one we tend to use most often is myocardial perfusion imaging. It's readily available to us here. And in fact, it's quite a useful test because it effectively stratifies women with symptoms. So if you have a negative system-maybe or cardiolite stress test, it essentially reassures you to say that the event rate in this individual will be exceedingly low. So myocardial perfusion imaging is probably the first kind of stress test if the stress test or other imaging modality doesn't help you. What about coronary reactivity in women? Now, microvascular dysfunction is one of those factors that have been implicated in this pathogenesis of ischemic heart disease in women. And when they did autopsy data in women who died of myocardial infarction, and what they found was more plaque erosion and distal embolization, which we know, in fact, predisposes you to microvascular dysfunction. They also tend to have much smaller arteries and more positive remodeling, and this leads to further microvascular dysfunction. We well know that endothelial dysfunction plays a role in the pathogenesis of ischemic heart disease. And in women, it's no different. When measured in the coronary artery or even the peripherally, such as the brachial artery, it certainly contributes to the pathophysiology of ischemic heart disease. So although not clear, some commentators have defined a sort of unifying hypothesis of ischemic heart disease in women. And microvascular dysfunction is central to that. And here it's more prevalent in women as a result, and this is the hypothesis, it's a result of risk factor clustering, vascular inflammation, the high CRP, remodeling, and hormonal alterations. And this is possibly, I'm not saying it's definitive, it's possibly the etiology for the paradoxical frequent symptoms of angina, non-anginal symptoms, ischemia, and adverse outcomes. So put it in a more graphic form, you can see, I'll use the, you get your traditional risk factors with the postmenopausal change, and then you get, the inflammatory milieu that with the high CRP, and then you get the abnormal reactivity with microvascular dysfunction, endothelial dysfunction, the positive coronary remodeling with increased wall thickness, plaque erosion, and distal embolization, and leading to obstructive CAD. And once you get microvascular dysfunction, you can get subendocardial epicardial ischemia, and this typically leads to the ventricular dysfunction on the right side with atypical symptoms, including prolonged shortness of breath, fatigue, etc., that we often see in women. So what about prognosis? I've said there's this consistent pattern in the literature of greater mortality in women. It's quite consistent. If we look, in fact, at our own data here at Johannesburg Hospital, we just reviewed almost 700 patients with myocardial infarction over the last 4 years, and there's a 15% higher risk of women dying of myocardial infarction in our unit than men, despite a lower admission rate, 15% higher risk of dying. Show you one study, the thrombolysis in myocardial infarction 2 trial. Patients with a myocardial infarction got admitted fairly early 1990s, got thrombolysis within 6 hours. And what happened? At 30 days, women still had a much worse outcome than men. Same therapy, thrombolysis for acute myocardial infarction, within the approved time interval. Why? Not quite sure. One of the problems or reasons why women do less well, and it's been alluded by someone else, is that women are treated less aggressively, partly because, as Naomi previously alluded, guidelines were just not there. There wasn't enough guidelines. So women are treated less aggressively, both in hospital and at discharge medication. Many studies have shown that at discharge, women don't get the same guideline-mandated therapy as men do, nor do they get the same guideline-mandated therapy when they're in hospital. Yet if you take ischemic heart disease and acute coronary syndrome, if they get aggressive invasive management, the outcomes are pretty good. So what's the future? Well, I think we need to understand the risk of ischemic heart disease in women. As I said, it's a huge problem, the highest cause of death in women. So we need to be aware of the major cause of mortality in women. And we need much better advocacy. Cancer has great advocacy. Cardiovascular disease in this country, minimal. We need to treat women once they present with coronary artery disease, ischemic heart disease appropriately. We need to give them guideline mandated therapy. Colin alluded to that we're only achieving 50% of therapy, even in those who have adequate health care cover. So we need to do much better than that. And finally, we need to focus much more research. I think much more research needs to be done in women with ischemic heart disease. There's a huge scope of research that needs to be done, and I think some of that work needs to certainly be followed through. Thank you very much.